pleasure to introduce Gilbert Donders. Gilbert Donders, a colleague from Belgium, is also president of European Society of Infectious Disease in OBGYN. And probably Gilbert will continue now to speak about prematurity and infection. Thank you.
Thank you, Francesca. Thank you, dear organizers, to have me back to Trieste. Like you, Ronnie, it's always nice to come back. I was asked to give a talk about prevention and treatment of preterm birth, so it's a little broader than just on infections, and I think as Ronnie ended his talk, we need to address this. Very briefly, we know that preterm birth is a major problem in the world, especially in the sub-Saharan African countries and in South Asia. You've seen this in former slides, basically, but we shouldn't forget that of these 15 million preterm births, 1 million dies. So a lot of these preterm deaths should be prevented by simple measures. That's what we think. We know there is a bunch of potential causes that we need to take into consideration, and at least two of them lead us to the discussion that we should look at infections as well. We saw in earlier speeches today that the preterm birth, instead of going down, goes up. Not the early preterm birth so much, but the late preterm birth is going up ever since. Is this a problem? It is a problem. We shouldn't think, and I learned that from former lectures today, we shouldn't think this is not of a problem to be born at 35 or 36 weeks because you survive, because as you can see, there is still a lot of morbidity. How does that come? I mean, we then try to explain, we think, well, it's maybe genetics, because that puts the problem to the women. If it's genetics, what can we do? It's their own thing. So then you look at the racial, ethnic differences, and of course you see data from the United States that compared to white women, black women seem to have a persistently higher rate of preterm birth. So you want to know why. But also in Europe, we're not doing very well. If you look at the European countries, what happened to the change of preterm birth over a year time in the period, 12-year period from 96 to 2008, you see in all these countries, most of the countries do have an increase in annual rate of preterm birth, not a decrease. This is for singletons that are having spontaneous preterm birth, and this is for singletons that have a medical, or call it induced preterm birth. So what we call medical, we find we have a reason to induce them. So you see here, but two countries, all other countries, seem to have an increase in preterm birth. This is for twins, it's even worse. For twins, we have even more fear that something goes wrong and we induce them. Is this a problem? Well, the more fetuses you have inside, the more problems you have, and the more admissions to the neonatal care unit you have. So it's a costly and it's a dangerous situation. This comes partly through the increase in artificial reproductive therapy that we apply. So we have much more of these cycles, we have much more of these babies born to these fertility techniques, and we should keep an eye on this, not to put back too much embryos, and we in Belgium were among the first 10 years ago to limit the number of embryos that will be placed back in the uterus to 1. Then there is the social economic story. We know that high income countries do better in general than mid and low income countries. So the preterm birth has a very multifactorial origin. So what can we do as an intervention? We have 3 levels of intervention. We have a primary intervention which is directed to all women that fall pregnant. Either before pregnancy or during pregnancy, we try to do something to prevent preterm birth. We have a second level, that is the secondary prevention, where we try to detect women at increased risk and then come into action and try to select a group of women that we give extra attention and extra treatment. And the third level of prevention of preterm birth we try is that once the labor gets active and a woman comes in with contractions and she has threatened delivery, we try to do things to stop labor and try to gain at least a few days to give the corticosteroids. So that leads us to this scheme that you all know. You can present it in different ways, but there is a bunch of things that do have an influence on the activation of the decidua and the fetal membranes. That can be infections, that can be the activation due to stress by the adrenal cortico-releasing hormones of the fetus, that can be decidual hemorrhage with thrombin formation, that can be uterine distension. All these factors cause a activation of the fetal membranes, which then lead to either prostaglandins or the metalloproteinases that we know, and all the other proteases and sialadases as you talked about. So this will make your cervix weak and weakens your membranes. This would then cause contractions together with the maternal oxytocin. So what we do as a mainstay of trying to prevent labor is give drugs that try to stop one of these pathways. That is what we are used to. That is what we call tocolytic therapy. That's what we think of as proper management of preventing preterm birth. On this side, there will be cerclage, of course. So, in order not to wait so long and come into action, what can we do? Of course, a lot of people would say, if you think primary intervention, you have to eat healthy. We know if you eat olive oil in the southern part of Europe, where we are now, and you drink lots of wine, you live longer. So that must also lead to a better outcome in pregnancy, isn't it? That's the feeling we have. If we do a better nutrition, we will be better. And what we do is we listen to companies that tell us that we should give a lot of supplements in pregnancy, alpha, omega-3, micronutrients, and so on. And none of these seems to help a bit even to prevent preterm birth. Is there anything else we can do? What about birth spacing? There we have a check. What about antenatal care? We couldn't prove. What about smoking cessation? There is a check. What about emergency obstetrical care? Not much to be gained. I'm not talking about stillbirth because there we have better outcomes. So birth spacing, if you space the next birth with at least 24 months, you have an optimal interpartum interval. You have a 20 to 40% increase in preterm birth if you deliver the next one less than a year before the former one. What about smoking? There is a 30% reduction in preterm birth if you can quit smoking in the first trimester of pregnancy. There's good data for that. And in the workplace even, we can do some action and stop smoking at work. And if you do that, you can gain a 4% of women that do indeed smoke less, and then it ends up in a small decrease in preterm birth. So this is preventive action, primary preventive action we can do. What about infection then? What can we do? And I know we will have a small discussion, Ronnie, with your talk, with all of these infections that we were looking for, even asymptomatic bacteriuria, which was first claimed by Roberto Romero to be a marker that could lead to preterm birth and could be prevented. It does lead to preterm birth in some cases, but if you give treatment, it doesn't help. That is the main issue, and the main issue is the same for bacterial vaginosis. We know there is something with abnormal vaginal flora that causes preterm birth or is associated with it, but we don't know exactly right what to do, because most of the screen and treat mechanisms, as I will show you, were not so unconditionally positive as you may think after the last talk. And this is the main study. I know Ronnie doesn't like me to show this, but it was a big study from the New England Journal of Medicine with Carey that made a large screening of women, thousands of women that were screened for asymptomatic BV. And when they had BV, they were randomized in a proper way into placebo or metronidazole to see if you treat with metronidazole BV patients versus placebo, if you get a better outcome in terms of preterm birth. And ladies and gentlemen, it isn't. There is no single difference between placebo and metronidazole treated women in terms of preterm birth outcome. But it gets worse, because if you use the same drug, for trichomonas treatment, you get even more preterm birth. So metronidazole could even be, as you said, a dangerous drug, because you do make differences in the flora. You take out some anaerobes, but that may be in the advantage of some aerobes of other bugs that can cause more problems than you try to solve. So metronidazole wasn't a good idea. There is another study done in South Africa where they found similar data. If you, and this is not 30, but it's 3, so I forgot the decimal. If you give vitamin C as a control for women with BV versus metronidazole, and you compare it with normal women without BV, you see that, again, metronidazole in this group of Udendahl showed an increase in preterm birth instead of a decrease. Then came the clindamycin club that is done studies on vaginal or oral clindamycin treatment from 3 days to 7 days. And you see Austin and Ronnie's data there, and Herbert's KISS that come back all the time. And they seem to indicate that it could be beneficial to screen and treat in low-risk women, provided that you take the advantage of a broad spectrum antibiotics like clindamycin, so that you cover more than just the anaerobes, and you start early in pregnancy. So you've seen this before. So then comes the meta-analysis, and you've done one yourself that you published in 2011. I show you now the most recent one, which is published this year, last year in 2015, where they try to look, if you look to infections in the lower genital tract, what can you do to prevent preterm delivery? It's a Cochrane analysis, and they studied all published, unpublished, randomized studies, and so on. This is what they conclude. There is only one study, they say, which is well enough performed to make a conclusion. Only one. And that's Herbert's KISS one. That's the Vienna study that made a study group that were having findings sent to the gynecologist for further treatment, and a control group in which they didn't send the findings to the gynecologist. You do a gram stain, you do analyze if there is candida, if there's BV, if there is whatever abnormality, and if it's abnormal, you warn the gynecologist for treatment, and you don't warn them in the control group. So then, if you see, what happens is there is in the treatment group a severe reduction in preterm birth, so everybody is happy. But look what they've done. Is this a treatment study for BV? They give clindamycin, not only once, but more than once if necessary. They give post-antibiotic lactobacilli to everyone, and they give anti-candida therapy. So what is this treatment? What are we looking at? What is going on? We have now studies showing candida may be important. We have studies showing inflammation may be important. We have studies BV may be important. But if this is the only study they retain from a review, a systematic review, that gives treatment for all possible things you can find in the vagina, I don't know what we are talking about. I think we are talking about something, but really we don't know what it is. And if you look at the quality of this study in the same review, it's not all that wonderful, is it? There is only 2 greens, and all the other ones are question mark, and even here for the blinding of participants and personnel, it's a red. It means it's not a randomized, properly blinded study. It may be randomized, but everybody know what they were getting. Everybody know they have a problem or not. So they can go to the obstetrician more early, get more treatment and so on, which is not controlled for. So even that, I think, ladies and gentlemen, even though they say after a larger group of women. They have as much preterm as not preterm birth in the intervention group and published this. It may be okay, but I don't know what's happening. So then comes the most recent group that did the meta-analysis, the systematic review on BV in pregnancy in the Scandinavian countries, which are not biased and not pro or against, they're not religious on antibiotic use in pregnancy, do a large review and see they use the great quality, which is the new level of evidence that we use in meta-analysis nowadays, and they can see that the relative risk for metronidazole was 1.1 with intervals including 1, and also concerning clindamycin, they say at any gestational age the relative risk was 0.9, which again includes 1. Not so good as we would wish and hope. And they conclude the systematic review gives strong recommendation against treatment with metronidazole and a weak recommendation against treatment with clindamycin to reduce spontaneous preterm birth. This is the data. You see metronidazole causes the 1. You see clindamycin, even in clindamycin, if you see in the low-risk women altogether, they cause the 1. If you see the ones that are treated before 20 weeks, which is a subgroup analysis, you can see if you use these meta-analysis and these reviews, you can come to conclusions as you wish, because in this case, the latest one shows it is not beneficial to give clindamycin in pregnancy. And I think I know why. Because I've been saying for a long time that if you look in pregnancy, and this is our data from the Belgian preterm birth study that had no intervention at all, but you just look carefully at the flora. That means you do the dust from your microscope, you look again what's there in the vagina, and you look in the first trimester what's there. You can see the most important thing that you spot is abnormal vaginal flora. If you have, and I agree with you, Connie, on that, if you have abnormal vaginal flora, you have an increase, a tremendous increase versus normals of preterm birth before 37 weeks, of preterm birth before 34 weeks, and of preterm birth before 24 weeks, just by looking at the lactobacillus. So if the lactobacillus is gone, you have lactobacillus grade 3, as I call it, or 2B, you have a problem. But also you can see if you have here the BV group, what I call partial BV, and I can't show you today because of lack of time, but that is BV with this mixed with other flora. It's not full BV as you would call full born BV, or did you? Born door BV. This is born door BV. This is full-blown BV. It's the old picture is full of abnormal anaerobic flora, the granular picture with all the clue cells that you're used to. And you see, this is not the entity that gives the most problems. It gives some problem at less than 24 weeks, but not in the other groups at all. The partial BV group is important, but also, as you can see, the coccoid AV group, which is aerobic vaginitis with aerobes, causes similar problems than this group. It is a very important finding that we should look broader to the bacterial flora and not just focus on full-blown BV. So what I have as a conclusion out of this, ladies and gentlemen, is what matters is not so much the presence of BV or the presence of anaerobes, it is the absence of lactobacilli. So you agree, huh? I can see that. So let's just quickly move to secondary interventions. What can we do to make women at risk have a better chance not to deliver preterm? First of all, we have to find them. We have to define who is at risk for preterm delivery. And how easy or how difficult is that? The best predictor for now, as far as I'm concerned, is the fact of having had a previous preterm birth, and I agree with you again, Ronnie, that it has to be in studies mentioned, is the most predictive likelihood to have another preterm birth. If you have 1, you have 20%. If you had 2, there's 40%. If you had 3, there's a 60% risk to have another one. Then we have the tests. We have the uterine contractions that we see on the tokogram. Positive predictive value 42. Fetal fibronectin 43. Short cervix 43. Both combined 47. Not too wonderful, isn't it? These sensitivities of these tests are still very low. We pick only 1 in 2. Sensitivity is low and the positive predictive value is low. So if it is negative, you can say something. You say most likely nothing will happen. But if it is positive, you don't know if this woman will or will not deliver. So we don't have these wonderful tools. But then if we think we have, what do? We put them to bed? No, no longer. There is no evidence whatsoever that this helps. Do we look at exercise and workload? There is conflicting data. I've been into that and I lost my way. There is people that say if you have hard work, you deliver more preterm. But then there is others that say you should do exercise, because if you do exercise, you have less preterm. So I don't know what it means. There is people that give omega-3 nutritional supplements with some findings there that seem to be promising, but that was again not confirmed by other studies. One thing is confirmed, it seems, that is the use of progesterone. If you detect a woman at risk, you have a small cervix, you have fetal fibronectin present, you can start using progestin to prevent preterm labor, and this seems to work. And now there's a recent meta-analysis of this year showing that there is less preterm birth, less than 34 weeks, with a nice confident interval, relative risk of 0.66. And there is also some data on cerclage, that cerclage seems to work if you have a short cervix of less than 25, you have a benefit. If you have a cervix less than 15, you have a big benefit to do with cerclage. So there is still place for cerclage in some selected women, depending on the length of their cervix. So finally, Mr. Chairman, we come to the last part, which is the tertiary interventions. So we have now labor. We know these women will have a high likelihood to deliver. What do? Well, we've been developing a lot of products and we've been investing a lot, and including myself, done studies, have conferences on what type of tocolytics we can give to stop labor, and only one seems to work, and that's the COX inhibitor, which we don't like to give too much for the baby, because all the other things don't seem to cause the test. The delivery, preterm delivery of none of all these items seem to be helping much to prevent. And we have that experience ourselves. Let's be honest. The women that really are in labor, you can't stop. The women that we do stop are the ones that would stop anyway. They wouldn't deliver, isn't it? So I don't think there is too much place of this. And the COX inhibitors, we can give that once or two times, but not too much. We don't like it for the fetal cardiac function. So what will we have in terms of infection, ladies and gentlemen? We have this cascade that I showed you. You have the cytokines coming. You have the metalloproteinases and the prostaglandins that I showed you in the other diagram, which leads to preterm birth. We can stop this with indomethacin. We can give dexamethasone. This is animal data that work very well. But why don't we try and stop this intrauterine infection? Because before the bugs go to the decidua, nothing will happen. So we have ascending infection in order to have this. This comes from the cervix, this comes from the vagina, this can be BV, this can be AV, this can be trichomonas, who knows? And then is of course the quality of the fetal membranes in some and the quality of the cervix in others that matter. So if we say in order to prevent ascending infection, we need to cut on the number of anaerobes in the vagina, because we know there is high loads of anaerobes and they may predispose for miscarriage and preterm birth. So what does the clever gynecologist do? Let's give antibiotics. But then you come to studies, and you showed elegantly in the former lecture that the new techniques with the PCR-based techniques to find new bugs, new bacteria, 80% of which we didn't know they existed, and you look in spontaneous preterm cases and in term cases, all these bacteria, including the bacterial vaginosis associated bacteria, the Megatosphaera, all the other ones, there isn't any one of them as a single bacteria that makes a difference. In spontaneous preterm labor or in term births, there is no difference to be found in recent studies. So it seems to be that Monarchopis sometimes has the wind ahead and it doesn't go as we wish. So what I think is what matters is not the presence of BV or the anaerobes, it is the absence of lactobacilli. So if you look then, what happens more is, in order to get birth, you need IL-8. In order to get preterm birth, you also have an increase in IL-8. So the cytokines in the vagina matter. We know that. If you look at AV versus BV, and you look at the cytokine patterns, you see in BV, there is no IL-6 at all. There is no IL-8 at all in BV. But in AV, there is a tremendous lot of IL-6 and IL-8. And also for IL-1, there is much more in BV, in AV than in BV. So why don't we consider aerobic vaginitis as a risk marker for BV, for preterm birth? Here you have the two extremes. This is the full-blown BV. There is no cytokines, there is no inflammation, no leukocytes, while in the other side with AV, you have lots of cytokines, you have lots of inflammation, you have toxic leukocytes. There is a lot of reaction of this woman. There is host response that is important, and this should be taken into account. If you look at sialidase levels, they are both in BV and in AV present in similar numbers. And if you look at the cervix, you can see that severe AV causes a short cervix in less than no time, starting from 20 weeks on. And if you look at delivery, you see that the cocoid AV doesn't cause overall too much of preterm labor, but before 34 weeks, which is of most interest to us, there's an odds ratio of 2.4, and less than 20 weeks, there is an odds ratio of 4. So AV matters as well, and maybe as much as BV does. Is it difficult? No, it's not difficult. And we can come back together with Francesco, we can do a course for microscopy, and you will easily pick it up. It takes you a couple of hours training. Last slide is about the lactobacilli, even the lactobacilli, and this is now a Lactobacillus crispatus, which we know is very protective in pregnancy, does seem to cause a protective less production of IL-1 beta, IL-1/6 and IL-1/8, even if there is BV or not BV present. So the quality of the lactobacillus in terms of being anti-inflammatory on itself is also a part of the game. So therefore, we should maybe better look for the absence of lactobacilli plus the presence of inflammation. And I think, ladies and gentlemen, that summarizes more or less what I wanted to say. So therefore, instead of using antibiotics, why wouldn't we start considering to see probiotic use? There is not much information. Actually, there's no information. This is one study recently that shows that there is not much change with oral probiotics in pregnancy in terms of improvement of the flora. But we are planning on a new study which uses oral and vaginal products in a proper way. We will do a proper study that is completely blinded and completely randomized to see in 4 visits what will happen to these women. I want to thank you here, and just before coming to my take-home messages, show you this slide which comes from our website. As been said, go please and sign up as a member of IZDoc. You will have a lot more of this interesting information. Lots of these people in the front rows are already members. And we will have a next conference in Vienna, the 26th to 29th of October. Please come and attend and send your abstracts in. So these are the not 5 take-to-home messages, but take-to-work messages. One is that in the prevention and management of preterm labor, we still have many beliefs that have no scientific support. The importance of BV as a risk factor of preterm birth is confirmed, but also other types of abnormal flora, such as AV, are important risk factors. I'm convinced of that. The A-specific and easy parameter of the lactobacillary grades, just look at the lactobacillus, together with the presence of inflammation, is the best marker for prevention of BV, or at least for recognizing the risk factors. Antibiotics for anaerobes, both, are less promising as originally thought and should only be given with extreme care. I don't think there is a need to give nasty antibiotics to women just because they're pregnant and they have an abnormal flora, because we don't know actually what happens. We don't know what we're doing. We're causing increasing resistance patterns, we're causing the bacterial flora to shift, we don't know in which direction, and we're not completely sure this is good. I mean, in oncology, we would never do this with this evidence we have. Probiotics are an interesting alternative, but require further testing. So thank you, ladies and gentlemen, for having the patience to listen to me.
Thank you so much, Bert. Yes,
Yeah,
please.
absolutely.
Much of what you say I agree with, quite a bit of what you said I disagree with. I just wanted to bring your attention to the Danish study that you showed there, published about 3 or 4 months back. They tried to call it guidelines. I was actually one of the advisors on that, and I advised against them coming to that conclusion. But they went ahead and published it anyway. They tried to publish it as guidelines, but the editors and the reviewers were unhappy about providing it as guidelines. And there was an argument going back and forward, and they eventually decided just to call it a systematic review, not guidelines. I think they said recommendation, but it was basically a systematic review. Those of us who were interested in it, myself, Jeffrey Keelan, Piggy Larsen, and Jan Steiner Jorgensen, I'm a guest professor in Denmark, so I didn't like to hear that coming from the Danish guidelines. We offered to do a commentary for the Scandinavian Journal. They said that there was going to be an editorial to follow it. The editorial did follow it. The editorial criticised the use of the grade system that you mentioned. Basically, it said that to do the grade, you have to be well trained to do it. And the first author on that is a medical student. And none of the rest of the people have ever done grade before. The other thing they said about grade was that the grading system, it can be wrong in the sense that a recommendation, the evidence could be poor quality, but the grade of recommendation can be strong, and that doesn't always work together. Just one last thing. If you look in this week's journal, you'll find our responses there. They let us write a commentary, and it's 3 days ago I got an email to say it's there. You'll get it online, and you'll see us shooting down that the Danish study there. They left out one very important study, which is Austin's. Where's Austin? They left out one very important study. Had they included that one from Austin, it would have completely changed the results. The other thing they did, which was completely wrong, was they included the Primiva data. Did you see that?
But they say in their paper, even if they leave them out, it's still negative.
No, they didn't. They left it out, and they did a calculation, and it changed the significance, and it made it significant. But when they did their conclusions, they put in the fact that the Primiva was there. So again, if people are looking at the big picture, they're not looking at the detail really.
But it shows you, if you are religious about something, you can prove whatever you like, even with systematic reviews. And this is why you need common sense.
No,
and without inflammation and lack of lactobacillus, there is no common sense.
The Primiva study, just to let people know what the Primiva study was, there was a study published in, it was an abstract form at the SMFM in 2012. The abstract appeared 2013. It was a good study. It was clindamycin used early in pregnancy in women with bacterial vaginosis, done in France, and it showed no benefit. And I got phone calls from, not from Gilbert, but from other people saying, nah, I told you were wrong all along. That study's never been published, and we've tried to get details about it to see why it's published. And you and I were on a meeting in Paris together, I think last year, and one of the Primiva authors was there, and we asked her why they hadn't published it. And when I spoke to Piggy about it, we said, it must be the diagnosis of BV. And that's what she said at that meeting. Our diagnosis was wrong, so we're not publishing it until we can review all the diagnoses. And we're going to do it molecularly this time round, but they're actually going to use glass slides, the gram stains. And so they should never, the Danish guidelines should never have used that. It's only been published in abstract form, and it would have changed it had they not used it.
But I would oppose that by saying that a lot of negative data are not published. So there is always a bias, because everybody has p-values publishes, and everybody who has not p-values but doesn't dare to publish because you're being shot by believers and religious people. I've been through that all my life. So it's very difficult to publish negative data. I think there's much more negative data out there that are not published. So even that, taking that into account, I think we should be careful really by giving antibiotics. I'm not sure if we have enough reason to do so for now.
Austin, any comments?
Not many. The reason I'm talking about CTG today is so I stay well away from this fine line.
And Ronnie, we have different vaginotypes, and probably these different vaginotypes are related to the ethnic group. This means that probably the presence of the absence of lactose is not just physiology or pathology, but it's a different milieu in different women. This is a big trouble for diagnostic pattern for us, which means pH is normal 4, 5, 5.5, or is normal in Caucasian women, in Hispanic women, or in black women.
I agree with you 100%. And we know that the rate of preterm birth, you showed it in America, is twice as common in black women than it is for white women, but they reckon that 50% of the difference is due to infection. Bacterial vaginosis is 3 times more common in black women than white women. And you're talking about inflammation. We know that the profile of cytokines in the vagina are different in black women with BV compared to white women with BV.
But I did studies in Uganda and in South Africa. What everybody calls BV is not always BV. I did microscopy. I looked at all these women myself, and half of the so-called BV is AV. It's not BV. As long as studies, as you say, we have to have a proper list of things that should be looked at in studies. As long as we don't look at AV and just at BV and diverse women in BV women or not BV women, and that's it, we will never get there. If we don't look at AV, which is an aerobic condition with inflammation, we will never get it, because if we leave it out deliberately, we will miss out of an opportunity to find the real associations. And that is what makes the difference. We also don't know what antibiotics like clindamycin do on AV. It may be helpful in lots of them, it may be not, but we don't know yet.
Yes, but maybe that the correct definition is no more bacterial vaginosis, but maybe vaginal dysbiosis or
Abnormal vaginal flora.
yes, or bacterial vaginosis syndrome, for example, but no more bacterial vaginosis because
And no more syndromes, please.
no more syndrome.
Do you think we don't have really good results with antibiotics, but do you think that probably clindamycin is a little bit better results than metronidazole because we are able to cover other microorganisms, E. coli or mycoplasmas or BV anaerobes?
No, I do agree. I do agree. If you were to choose in pregnancy, and I've been saying that since 15 years, why is metronidazole not the answer and why is BV not the question? I think clindamycin is a better choice than metronidazole for sure in pregnancy. But I don't know if it's safe enough because we don't know what we're doing. We're just changing the flora. We don't know if it still give chance to some bacteria that are not in the spectrum or being resistant to clindamycin, because that's a big problem also. We induce a lot of resistance. And I'm afraid that if we continue like this, we will end up with problems.
In your take work message, intermediate score, it's an open door toward physiology or pathology. We have to treat or not, antibiotic or probiotics, because the intermediate score is a big problem for us.
But you know the answer. You are again saying that we should use a gram stain to divide women in BV plus, a BV no, and then we're left over with a group we don't know what it is. Why don't you look at AV? It will tell you what they have. Either they have BV, or they have AV, or they have both together, or they have Candida, there's Trichomonas. You know, at least you know what you're treating for, what you're looking for. So I think intermediate flora will never help us because it's a garbage bin of a lot of things. It is partial BV together with AV, and it's a mixture of things. So we don't know what we're talking about.
I think I would say that if you've got partial intermediate, would be to leave it rather than treat with antibiotics. To leave it because it's usually on a continuum from people moving from normal to abnormal or from abnormal to normal. So you should probably do nothing with it and check them again 2 or 3 weeks later. That will tell you. Just another couple of points about clindamycin. It's anti-inflammatory, which might help with your aerobic vaginosis. The other thing is that we haven't talked about the role of. I didn't put the slide up there. There's only a limited number of slides I can put there. Otherwise, it would have been another hour work. But we know that phage viruses are involved. Phage viruses parasitize lactobacilli, and it's a huge problem in the food industry. There's about 160 lactobacilli. Most of them are used in the food industry, and phage viruses, which colonize those lactobacilli, are a major problem in the food industry. We now know those phage viruses can be transferred sexually. We know that they can colonize lactobacilli in the vagina, and that may be something to do with the bacterial vaginosis story or the lack of lactobacilli. Now, if you use metronidazole, I don't have time to show this, but if you use metronidazole, you conserve the lactobacilli, and people assume that's a good thing to conserve the lactobacilli. And clindamycin kills the lactobacilli, so people assume that's a bad thing to kill lactobacilli. But if you've got a woman whose lactobacilli are colonized by phage viruses, then by giving them metronidazole, you're potentiating and perpetuating the problem. Maybe you should be giving them clindamycin to kill the existing poor quality lactobacilli that's there and let healthy lactobacilli grow in its place. And one area I do agree with Gilbert is in the possibility for future for probiotics. But I think we'll be using antibiotics to clear all the abnormal flora and then give them the healthy flora afterwards.
That could be as adjuvant therapy. As we speak, there is a meeting on phage therapy, potential phage therapy in Germany, where I was supposed to attend, but I chose to be in Trieste today. So, thank you.
Yeah, there was there was a paper about bacterial vaginosis some years ago.
Yes.
And there was a relationship between dairy products and recurrent BV. Yeah, right. Cigarette smoking. Yeah, right.
It's not, Gilbert. I know that you have experience with the decalinium chloruro. So what about the antiseptics in this field?
That's a good point. In Uganda, we tested decalinium because we have there's more than 60% of black women in Central Africa have an abnormal flora. That's why they have probably also such a high preterm birth risk. So we tried, but that's outside pregnancy. We tried decalinium chloride in these women, and we could indeed find, even after 5 days of treatment, or 6 days, I believe it was, after a month, you still see a benefit on the flora. It's been accepted for publication, now it will come out soon. So this may be a way to go, because it's not absorbed, it's just disinfection, but we don't know how often to use it, what it does on the long term, and there is no studies at all in pregnancy yet. So, but that's a good point, yeah.
Any question? One last question. In the study of microbiome, molecular technologies show that probably during the pregnancy, the intrauterine environment, intrauterine microbiota, is related to the oral, not to the vaginal microbiota. This probably could open for the future a strong relationship between parodontitis or diet or other vaginal or intrauterine pattern.
Yeah, we've published a couple of times on the association between periodontal disease, bacterial vaginosis and preterm birth, so I'm sure there's a link there. I don't know much about the decidua microbiome, but there was a paper published by Kirsty Ogor a couple of years back showing that the placental microbiome is more similar to the oral microbiome than it is to the vaginal microbiome, but there's some doubt about that, and there's a bit of backtracking on that as well at the present time.
Okay, thank you.
So thank you very much. Thank you very much, Gilbert. Thank you very much, Ronnie.